Welcome to our third NUGoKidney webinar. I am very delighted to welcome our guest speaker for the presentation today. It is a really privilege to have Dr. Locke, with us today. So, as a way of introduction, Dr. Locke is an abdominal transplant surgeon specializing in innovative strategies for the transplantation of incompatible organs, disparities in access and outcomes after organ transplantation and transplantation of HIV-infected patients. Dr. Locke completed her undergraduate studies in biology and chemistry at Duke, her medical degree at East Carolina University, and then moved to Johns Hopkins, where she received her training in general surgery and transplantation. She completed a Master of Public Health at Johns Hopkins Bloomberg School of Public Health, and she's currently Professor of Surgery and the Arnold Dethelm Endowed Chair in Transplantation Surgery at the University of Alabama. She also serves as the director of the Comprehensive Transplant Institute, and she is the chief of the Division of Abdominal Transplant Surgery. Her research interests include complex statistical analysis and modeling of transplant outcomes and behavioral research focused on health disparities. She has published more than 140 articles, 20 book chapters, and she is an NIH-funded investigator. She is the deputy editor for the American Journal of Transplantation, and she is an editorial board member for the Annals of Surgery. She is a member of several societies, including the American Society of Transplantation and the American Society of Nephrology. She has been the recipient of numerous honors and awards, including the UAB Dean's Excellent Award in Research. She has been named the 2016 James Association of Surgeons Travel Fellow Top 40 Under 40 by Birmingham's Business Journal. She has received the American Society of Transplantation Clinical Science Faculty Award in 2020 and several others. With this, I will pause. Again, thank you so much, Dr. Locke, for being with us here today.
There we go. Thank you so much for that kind introduction. It's really great to be here. Just a shout out to my transplant medicine and surgical colleagues at Northwestern. Many of them I just recently saw, but good to be here with you all today. And excited to share with you a little bit about the first in-human clinical grade kidney xenotransplant that occurred back in September of last year. Full disclosure, this really, I think, represents the work of many people over many, many years. I just happen to be the person that was fortunate enough to be able to sew this graft in, but certainly we're standing on the shoulders of many people who have gone before us. So I do have a couple of disclosures. So it's important to note that the work I'm going to be sharing with you today was in fact sponsored by United Therapeutics and its subsidiaries, Lung Biotechnology that sort of provided the grant, and Revivicor that provided the gene-edited pig. And then I have a couple of other activities. And of course, the pig kidney that I'm discussing technically is off-label use. So we will be discussing that quite directly today. So I thought I would start by talking a little bit about something I think everyone on the call is very familiar with, and that is that the organ shortage is absolutely a lethal problem. So if you look, currently there are close to around 90,000 people or so waitlisted for a kidney transplant, and we really perform fewer than 25,000 every year. And if you look, our transplant curve has really been flat for about the last 20 years, and that's really despite our efforts to increase. And you can see that shown here in the bars. And we know that 40% of waitlisted patients will be dead in 5 years. And so really the organ shortage is a refractory, severe, and impactful problem that really needs a radical solution. And I would argue that it's even more impactful than what this graphic shows. I think for the nephrologists in the group, there are about as you all know, there are about 700,000 Americans that have kidney failure, and we have fewer than 100,000 waitlisted. And so the problem is much bigger than the wait list actually reflects. So this is something that certainly even the government has recognized. So under the Trump administration, there was an executive order on advancing American kidney health. And really, I think there was a lot of emphasis on trying to get as many people as possible transplanted, as well as to encourage the development of sort of artificial organ sources. And in many ways, you could consider a porcine xenograft one of those such modalities. So then how do we go about this? And it's really sort of the impossible solution, which is xenotransplantation. How do you take a kidney from a porcine source and have it actually be able to work and function in a person? And this was really, I think it's important to introduce you to someone. This is Martine Rothblatt, and she's the chairwoman of United Therapeutics. And that's really sort of the impetus for where the title came from of the talk. But Martine is really a remarkable person, but she was quoted once as saying that her approach when people say something is impossible is that she just drives an axe right between the letter M and P. And she says, no, impossible means to me that I'm possible. And so she's going to figure out a way to slice the problem up into little pieces until she solves it. And Martine is really remarkable. She has really, I think, driven xenotransplantation, and she came to this. She actually invented Sirius XM satellite radio. When she got out of that business, it was really related to the discovery that her daughter was born with pulmonary hypertension. And I think really Dr. Rothblatt's goal was to really be able to have a lung on a shelf if her daughter ever needed a lung transplant. And so she's really been committed to this and has been a big driver behind xenotransplantation. And if you have time, Google her. It's a really remarkable story and really remarkable person. And I think she is given the plenary this year at the American Transplant Congress. So check her out this June. So how do we go about doing sort of the xenotransplant piece? And really, it's all about genetically modifying or humanizing pig kidneys. And really, we had to overcome essentially a couple of things. One is the immunologic incompatibility as well as viral transmission. And really, it was the advent of CRISPR-Cas. And you all may remember in 2020, 2 women scientists won the Nobel Prize in Chemistry for the development of this. And it's really revolutionized genetic engineering in general. And certainly the field of xenotransplantation has begun to leverage this. And through high throughput engineering, we've been able to engineer some human compatibility, as well as in some instances address the issues associated with retroviruses that have been of concern. And so we've really seen the field take off, I think, as a result of this and really make progress that it hasn't seen in the last 30 years. And it's part of why you've probably heard and seen a lot about this in the lay press as of recent. So with xenotransplantation, the majority of the work done to date has really been in non-human primate models. And so this is some work that we've certainly been involved here at UAB, as well as other centers around the US. And really these sort of porcine grafts have been genetically engineered to look less foreign to the human immune system. And we have settled on a 10 gene edited pig, and this is really involves the knockout of 3 key pig xenoantigens listed there, as well as knocking out things related to the coagulation cascade, as well as complement, inflammation. And then most recently, the knockout of the porcine growth hormone receptor. And that really became quite important because prior to doing that, the porcine grafts would continue to grow within the non-human primate model and actually outgrow its host, which was quite problematic. And so with the porcine growth hormone receptor being knocked out, that is no longer an issue. And you can see here on the right-hand side of the screen, this is a 10 gene edited pig kidney that's been sewn into a baboon model. You can see that the kidney looks relatively normal. This is the ureter here that I'm pointing to. The ureter, now that we've knocked out the growth hormone, has a little bit different characteristic. It actually is much larger in diameter than we typically see in a human ureter. It has sort of this really thick adherent fat around it, and its blood supply seems to be a bit more tenuous. So there have been some technical things that we've had to work out to ensure that we don't have urine leaks and other things. And then the other issues that we've noticed once we knocked out the growth hormone receptor is that the blood vessels themselves seem to have be just much more fragile, both the artery and vein. And so we've certainly tested this in a non-human primate model. We have shown that these kidneys function, they produce urine, they decrease creatinine, they tolerate the systolic blood pressure of a non-human primate model. But what we have not been able to really ascertain is that non-human primates, despite being quite similar to humans, are in fact immunologically different than humans. And we've never really been able to test this model with conventional immunosuppression, which is something that certainly regulators like the FDA would like for us to be able to do. Importantly, we also, at this point, had not really developed a immunologic assay to test compatibility between human and pig, and nor had we ever been able to validate any such test in order to sort of a priori guarantee that we would not have hyperacute rejection in a human model or in a human recipient of xenotransplantation. And so it was really these key critical knowledge gaps that we just felt like we needed to be able to answer, but we wanted to be able to do this prior to moving this into living persons. And so I guess it's 2.5 now, 3 years ago, we started exploring the concept of could brain death, human brain death, actually be a preclinical human model to study and be able to answer these questions and be able to do this without actually risking a living person's life. So as I mentioned, the design advantages being no harm to a living person allows us to really be able to test our engineering in an actual human, but before you put it in the living, and then also really to be able to test our immunosuppression, or at least that was certainly one of our hopes. And so with this, we began quite a long journey, but our goal was to really partner with our organ procurement organization here in Alabama, known as the Legacy of Hope. It's important to note that we actually have a recovery center that is attached and affiliated with our hospital. So Legacy of Hope is affiliated with UAB, that is on site. They have now 4 critical care bays, as well as 2 operating rooms. And that's where the majority of our brain dead organ recovery occurs. And so the plan was to work with the Legacy of Hope to help identify a potential brain dead donor that either was deemed not acceptable in terms of having organs that would be acceptable for transplantation. So an example might be someone with a glioblastoma, or a kidney-only donor in which we could procure the kidneys for the purpose of transplantation, but keep the decedent's body sort of living, if you will, in order to perform the transplant. And then the goal would be to perform the transplant in our recovery center and then follow the decedent, ideally for about 7 days after the transplant, to be able to look at some early time points. And this, at the time when we started discussing this, was quite a radical idea, although certainly there have been discussions in both in the literature and through national and international organizations about leveraging such a model. You can imagine at an institutional level, it was certainly a lot to sort of grasp and understand. And we began quite a long journey with this. And we put together a pretty big study team. And we began actually with an external ethics review. We worked with Dr. Dominique Martin. She's an ethicist in Deakin University out of Australia, a prominent member in the Transplantation Society, has worked a lot with the World Health Organization, Declaration of Helsinki, etc. And really, after this external ethics review, it became very clear that we should probably be working with our IRB and actually do this under an IRB approved study protocol. And that's interesting because the decedent is actually deceased. It's a brain dead individual. And so by definition, that does not meet the criteria for human subjects research. And so it, in theory, falls outside the purview of an IRB. However, given the magnitude of what we were going to do and the fact that this was quite different than typical research conducted on brain dead individuals, for example, what's typically done, or at the time of procurement, additional tissues are procured for various research studies. In this case, we were taking a brain dead recipient and we were sort of suspending them in that space and sort of keeping everything going, all of the critical care support for a prolonged period of time. It was delaying the ability of the family to have access to their loved one. It was delaying the typical bereavement and grieving period. And so we felt that we needed the IRB to be involved. And importantly, we wanted what we were doing in this preclinical human model to as closely as possible replicate what we intended to do in a living person. And so with that, we began a journey with our IRB, and we ultimately did receive IRB approval in April of last year. We also worked closely with our IACUC, and that, of course, is the animal version of the IRB. It's important to note that our xenotransplant program has been in existence here at UAB for quite some time. It actually was started back in 2016. And at that time, in a collaboration with United Therapeutics, we actually built a pathogen-free facility that is in close proximity to the university, but in a non-disclosed location. And this is where we now raise and breed these 10 gene edited pigs in a pathogen-free space that would meet the FDA requirements that would be necessary to move this into living persons. And so we wanted to be able to coordinate and connect those efforts with actually doing a transplant in a living person. So in addition, at the pathogen-free facility, there is an operating theater that is designed just like a standard operating room, sort of meets JCAHO standards, with the idea that the procurement would happen there at the pathogen-free facility. The pig kidneys would be packaged, as is routine with any sort of deceased donor procurement, stored on ice and transported over a very short distance to our recovery center, where they would be transplanted into the decedent. So in other words, one of our goals was to completely replicate every step of the process that would happen in living people. We also had to work very closely with our reputation risk management team, media relations, etc. I probably presented this to every single person you could imagine at UAB, from the president to the board of trustees to the chancellor for UA systems. We ultimately, in addition to IRB approval, received institutional approval more broadly to proceed. We were fortunate in September of last year, actually, to enroll our first decedent. And we were able to perform on September 30th, the first clinical grade porcine kidney xenotransplant into a human being, in this case, a brain dead decedent was the recipient. And we were fortunate enough to publish this work in the American Journal of Transplantation. And it was embargoed until January 20th, which is why you all probably just learned about that in the lay press and through this published work in early January. But it was quite an exciting process, and I'll walk you through at least the initial study and tell you a little bit where we are overall and what our next steps are going to be. So I think the first thing that we did in this study is I think we have established brain death as a feasible preclinical human model. Our decedent was a man by the name of Mr. Jim Parsons, and I can share that with you. The family's been very open in sharing this. Jim was a great guy and had shared with his family his wish to be an organ donor upon his death. And his family felt very strongly that Jim would want to be both an organ donor and a research participant if those options were available. Jim was a blood group AB, and related to his accident, he suffered an acute kidney injury and had serum creatinine in the upper threes. And Jim was 57 years old. And so ultimately his other organs were ruled out, and ultimately they were not able to place his kidneys. But Jim was ultimately enrolled in our study and was our first decedent to participate and the first to receive a clinical grade 10 gene edited pig kidney. And you can imagine, I think, sort of the applications of this preclinical human model that could even extend beyond xenotransplantation. And I think it's just a real testament to Mr. Parsons and his family for their willingness to participate in this. There's a lot of ethics around this, and the informed consent process, I think, is really important because there is a lot the family needs to understand in terms of how it does delay their grief and their bereavement. And so I think it's really important. And potentially one sidebar comment I would make is that I would certainly argue, and I think the ethicist who's been involved in our work would argue, that we may actually need to rethink human subjects research, and this particular preclinical human model might be best served under the purview of an IRB, and happy to take more questions on that after the talk. This figure is really depicting sort of what happened with our first decedent model. The pre-transplant phase lasted about 19 hours. By the time Mr. Parsons was enrolled in this study, he had been brain dead for 5 days. At the time, after enrolling and ensuring that we had what we thought was a negative flow cross-match, we began with bilateral native nephrectomies such that Mr. Parsons was anephric. We then performed bilateral renal xenotransplants. We implanted them separately. We put the right kidney on the right side and connected its ureter to the bladder and measured its urine output through a Foley catheter, as would be typically done. The left kidney was sewn into the left external iliac artery and vein, and that ureter was brought out through the skin as a urostomy so that we could separate out the urine output from the two kidneys. We then kept Mr. Parsons in that operating suite and took care of him as a critically ill patient for the ensuing next 3 days. I can tell you trying to battle brain death was something quite extraordinary. At the time of transplanting the xenografts, he was already on 3 vasopressors. So we were really sewing this in an environment in which you would not normally do a kidney transplant. He was also in DIC at the time of the xenotransplant. So you can see some of the limitations of this model. And then at the conclusion, we did perform xenotransplant nephrectomies and took multiple tissue samples. So what did we show and what do we mean? So as I said, we did the first clinical grade, and what we mean by clinical grade is that there is the pig was raised in a pathogen-free facility. And this is really important. We worry a lot about the transmission of porcine endogenous retroviruses, in particular PERV-C, which has been shown to be able to integrate in the human genome. And that is one of the things that we're very concerned about. Our pigs in the pathogen-free facility are negative for PERV-C. This is the donor 10 gene edited pig. Sorry for some of these pictures. But you can see on an operating room table in a standard operating suite, prepped and draped like you might imagine. This is really hard to see. Not surprisingly, pigs are quite fat. This particular pig was about 250 pounds, a little over a year old. And so you can see a lot of the fat buried in here are actually the kidneys, one there and one there. This is them on the back table. It's hard to make heads or tails of any of this, but I can assure you that the pig kidneys are present there. We actually procure these in block and try to keep as much of the surrounding tissue as we can, because as I mentioned, the blood supply to the ureter, the mesoureter that contains that blood supply is quite fragile, and it's easy to disrupt it. So we try to leave a lot of that tissue around. So that is what we mean by clinical grades. The kidneys were procured and packaged. They were then transported to UAB. So this is the teams. We had a separate surgical team out at our pathogen-free facility. This is Dr. Arandi, one of our transplant surgeons, and Sarah Macedon, one of our transplant OR nurses, coming back from the pathogen-free facility. This is the box with the cooler with ice. The pig kidneys are in. And these are our operating suites here in the recovery center. This is a picture just showing you the right upper quadrant. This is the undersurface of the liver and the gallbladder. This is a picture of the vena cava, and what we're trying to show you is that we have removed the native kidneys. This is showing you a picture of the right native kidney being removed. This is a picture of the 10 gene edited pig kidney. We're implanting it. Blood flow has not been restored to it quite yet. So you can see its sort of pale appearance here. And then this is immediately after reperfusion. You can see we have a nice pink kidney. It had a great, this is a little Doppler probe. It had a great Doppler signal throughout the kidney, and within just 20 minutes, the kidney began to make urine. And I can tell you it was a truly sort of remarkable moment. I think we all had held our breath, and we're really glad to see it functioning. And why had we held our breath? Yes, we've done a lot of non-human primate work, and we've shown that there's been no hyperacute rejection. But that's never been shown in a human being. And we had developed a novel flow cross-match to test for compatibility a priori. And we had predicted that the cross-match was negative, but the only way to validate that was to actually do the transplant and demonstrate that there was no hyperacute rejection. Had we had hyperacute rejection, that pig kidney within a few minutes of reperfusion would have turned black and began to necrose. So the other thing that we accomplished was the development of the first flow cross-match for human use. So we performed a prospective cross-match. We did this on frozen PBMCs. You can see our negative and positive controls and then our decedents, and we predicted a negative cross-match. We then performed a retrospective cross-match from the day of transplant, and this was using fresh blood. And you can see that that was negative as well. And importantly, we did show that it worked by not having hyperacute rejection. So as I mentioned, the xenotransplant occurred on September 30th. We elected to do, as Dr. Kirk described in an editorial, we used about the most vanilla immunosuppression regimen you could imagine. So we used our standard regimen for our incompatible or highly sensitized patients. We used lymphocyte depleting induction along with IV methylprednisolone steroid taper. We did give 1 dose of rituximab, and then our maintenance immunosuppression included a calcineurin inhibitor, mycophenolate, mofetil, and prednisone. And you can see this is our pre-implantation biopsy here of the pig kidney. It looks quite similar to a human kidney. 24 hours post-reperfusion, however, we did begin to see some evidence of thrombotic microangiopathy, and we saw that persistent on a 72-hour post-reperfusion biopsy, although interestingly, it had begun to actually resolve a bit and actually looked better when we looked through multiple sections. Now, what this TMA is related to is unclear. Could it be rejection? Certainly, but it is important to note that we did transplant this in the setting of DIC, so it could also be related to activation of complement and other things related to the brain death process itself. And what I can't show you, although I briefly showed it, I am no longer allowed to show it, is we've since gone on to do a third decedent actually, and we have added in a complement inhibitor, specifically eculizumab, and we now show, again, excellent graft perfusion and graft survival, and we show no evidence of thrombotic microangiopathy. And that really recapitulates some work that was done in a non-human primate model by the Tector group, in which they used a complement inhibitor known as teclistamab that works in non-human primates, and they showed similar findings. And so we now have modified our immunosuppression regimen to reflect that of what we typically use for an atypical HUS patient. And we think that's probably the regimen that is going to be necessary for clinical trial. So more to come. So what are our next steps? And this is why I've been a bit vague. We are currently working on an investigator-initiated IND. We, in fact, have a meeting with the FDA early next week. We also are working and have submitted our IRB approval, or submitted our IRB application for approval of a phase 1 clinical trial. We are proposing to study 20 participants over a 5-year period. And we do have currently pigs available at our pathogen-free facility. We have a set that will be really ideally ready between March and June, and then another set that will be ready in August. And we would certainly like to make use of these in the context of a phase 1 trial. I think you probably also heard about the heart transplant that occurred at the University of Maryland. That heart came from the same 10 gene edited peg that we used the kidney from. The heart works quite well, excellent function on echocardiogram, and in talking to Bart, you know, it sounds like the function of the heart was never the issue with the patient, but I think there's more to come, and I know they're looking to publish those results. And my hope is that at least early success will give the FDA some interest in hopefully approving a phase 1 trial for kidney xenotransplantation. And then, of course, I'm an abdominal transplanter. As I was mentioning to Sue, I'm actually on liver call right now. We obviously are interested in extending this beyond just kidney. And I think the next frontier will be liver. It's certainly much further away, but certainly I think the goal would be able to have you know, a 10 gene edited pig that could be used for heart, lung, liver, and kidney. I know a lofty goal, but certainly our next steps. And as I mentioned, this was certainly a team sport. This is just a fraction of the number of people. This is just the operating team that was involved, both out at the pathogen-free facility, as well as in the recovery center. One notable absence from this picture is Dr. Vanita Kumar, who's one of our transplant nephrologists and probably the smartest person I know. And Vanita was amazing in her scrubs down in the recovery center with us from start to finish, helping us manage the decedent as well as be able to collect the necessary data to hopefully be able to have a successful FDA application. So with that, these are very preliminary results. We have a lot more that'll be coming out soon, but hopefully this is a great teaser and really look forward to questions and comments and really appreciate the opportunity to visit with you all today. So thank you very much.
Thank you so much, Dr. Locke, for a fantastic talk, and so exciting to see how the future looks in the field of transplantation with exciting opportunities. So we have some questions in the Q&A, in the chat box as well. So I will start with questions that I got from Dr. Quaggen. What about the breeding of the pigs? So when you breed, for example, 10 pigs, how do you or will you monitor the acquisition of new mutations after multiple generations of breeding, etc.? How will you know the genetic makeup, and how could this affect the outcomes?
Yeah, that's a great question. So we confirm the genetic makeup of the pigs. So we've done that, and we do that each time. So I think, oh, sorry, I was reading another chat, but that's going to be super important. But we do confirm the genetics of each of the pigs as well as that particular litter. I can't go into all the details of how we do that because that is proprietary, but I will tell you that that's something that is monitored and we do ensure that.
Excellent. And then, the follow-up question here is that if there was evidence of TMA in non-human primates, will you need complement inhibition continuously post-transplant? Any plans to measure complement activity in serum of future transplants, for example, with cell-based endothelial assays? And the additional question here is, what do you know about porcine-specific characteristics of the endothelial cells, especially in the glomerulus?
Yeah, those are all great questions. So I think the answer is we don't know whether or not we would have to continue that. I think that is something that we will only be able to find out by actually performing the transplant in a living person, where we have enough longevity to actually be able to see whether or not we'll have to continue the complement inhibitor or not. To answer, are we going to follow these? Absolutely. That's built into the protocol and something that I think we will absolutely need to do. There are ongoing studies, again, and I apologize, I have to hedge on so many of your questions. They're all so spot on. I hope to be able to share more at ASN because we should be past a certain point. But the answer is yes, we do know a little bit about those endothelial cells, but I have to be a little quiet about it at the moment.
Sure. We have a question from Dr. John Friedwald, who is thanking you so much for the talk, and congratulations to you and the entire team. So his question is about the need to knock out the porcine growth hormone and the potential effects on the fragility of the allograft. Do you think that this strategy could be rethought in the long term?
Yeah, I think you're going to need to knock out the growth hormone, or I think you're going to have trouble with the pig kidney sort of outgrowing its host. We've really overcome the technical issues related to that. And I think it's really about surgical technique. And so we really don't have any issues now with any sort of urine leak. I do think it's something that's going to have to sort of be taught, you know, when we sort of people first start using these. And then the great thing, I think, and I should have mentioned it in the talk, that the decedent really also looked at is, could these vessels that certainly seem more fragile and, you know, can they tolerate human systolic blood pressure, and not just normal human systolic blood pressure, but the kind of pressures we see in our transplant candidates, because they have hypertension and other things. And I can tell you the decedent, you know, would have pressures that would shoot up to well over 200 during the course of this systolic, and the grafts tolerated it quite nicely. We didn't have any sort of bleeding complications related to the transplant, which was really great news and gives me a lot more comfort. I also, you know, those poor kidneys were like little pin cushions. I mean, I took a bazillion and one biopsies, and despite sort of having a thinner capsule, they stood up to the biopsies quite well. So I think we're going to be fine with it. It's just going to require sort of just careful surgical technique that I think can be easily taught.
Excellent. Next question is from Dorian Kaminsky, who is commenting a truly inspiring tour de force. And is there utility in editing out PERV A and PERV B in donor pigs, or are they not thought to be pathogenic in humans? And what about graft versus host disease post-kidney transplant, which is rare, but has been reported? Any thoughts in the setting of xenotransplantation?
Yeah, both great questions. So we certainly don't believe PERV A or B are going to be problematic. The issue is if you have PERV C and it recombines with PERV A, that can cause disease, and PERV C is really the driver of that. All pig herds have A, B, and C. You can get rid of C based on how you introduce. You have to take the pigs away from their mothers early after birth because that's transmitted through the milk. And so we certainly have done that with the introductions of the piglets into the pathogen-free facility. And that's how we manage to eliminate PERV C from the herd that is in the pathogen-free facility. The pigs in the pathogen-free facility do have PERV A and B. Again, we don't believe that that will cause disease. And importantly, in the decedent, albeit only out to 3 days, we did not see transmission of PERV A or B into the human decedent. So it does not appear that those were even transmitted. And so I think that's very encouraging. In addition, there is a group out of New Zealand that used islets, transplanted xeno islets, and they have about 7 years worth of data, and they have not seen any transmission of PERV. Now, albeit that's not a solid organ, but nonetheless, I think is some data to suggest that the methods that we're using are probably going to be sufficient. But certainly it is something that we will test for in the living human recipients. In terms of chimerism, I suspect that there probably is low-level chimerism, just as there is with human allotransplantation. And we had some preliminary, very early studies that we included in the original publication, but we also collected tissue beyond blood from all the various solid organs in the decedent, and we're going to have some more data coming out on that soon. But I think the likelihood of this causing graft versus host disease would be extremely low. And I don't think there's any reason to suspect or to think that this is going to be any higher risk than what we see in allotransplantation, at least based on what we've seen in non-human primate work.
Definitely, that sounds reassuring. Next question is from Dr. Lorenzo Gallon, who is basically asking that since the biopsy of the pig kidney transplant did not stain for IgM, C4d, C1q, and C3, the TMA is probably not the result of activation of the complement. Do you think that the 5 days of brain death could be responsible for the TMA? And how are you going to address this possibility in the future? And also, if you are able to address this issue, what do you think about a long-term accelerated vasculopathy?
Yeah, no, I think that's a great question. So I agree. I do think that this was related to brain death. The problem is I think we have to be able to sort of reassure that we can demonstrate that there isn't thrombotic microangiopathy. And so it was really important to us to actually do this in the context of using a complement inhibitor like eculizumab to ensure that we demonstrated no TMA. And we did that in a decedent. And so I do think, at least for the first in humans, it's going to be important to use something like eculizumab, because I think we don't want to take that risk, at least not initially. But it begs the question of, at some point, we probably need to test, can we actually stop the eculizumab? And so that's going to be one of the discussions that we have with regulators about how they view that. But so I do think for now, it's going to be something that we have to use. My hope is that it's not something that we'll have to use in the long term. But again, we're going to have to actually get this into living persons. I think it's possible if we could find a needle in the haystack and, for example, have a brain dead individual that is referred very early in the process, that is deemed very early to not be eligible to be an organ donor, where we could get and do this within the first day of brain death declaration. We might be able to do it and demonstrate no TMA. So before that brain dead donor goes into DIC. The problem is that's really hard to do. It's really challenging to find those. In the year that we did this, we had 5 different potential decedents we were able to approach, and we were able to successfully enroll 3 of the 5. So it's just, there's not a lot. And, our OPOs, we want them to be aggressive at trying to place organs for transplant, and we don't want to interfere with that process. So we don't even get involved with the family until they've exhausted the list. And that's why it's 5 days. And then we start our long process. So it's one of the, I think, significant limitations of the preclinical human model, and why I think we really need to move forward with doing this in living persons, because I just don't think that model is going to be reliable enough for us to be able to answer some of these key questions. It could take us 5 more years to find an ideal brain dead donor to answer that question.
Very true. We have one more question from the audience. What are the efforts maybe to do this in animals, non-pigs, for patients who have religious limitations? And how about mini swines? Dr. Jenny Zhang is asking.
Yeah, I can tell you, so why pigs? A couple of reasons. One, they're relatively easy to breed and reproduce rather quickly. They tend to have larger litters. And they also have a fairly long lifespan of about 30 years. So the thought is that hopefully those kidneys could last 30 years as well for a human. So those all become really important when you think about companies looking to fund this. So for them, there's got to be a return on that investment. And I think so having a source animal that you can sort of scale up relatively quickly becomes really important. And I think that's really been one of the main reasons for the pig to be chosen, as the donor source animal. And then I think in addition, there have been data to show that pig kidneys sort of, I think, do function similar to human ones. And some of our commonly used metrics, so glomerular filtration, renal perfusion, is very similar between pigs and humans. And so I think that's the other reason why people have sort of really focused on that. In terms of the miniature swine, I will be honest and admit I don't know how quickly or easily those animals breed compared to typical pigs. I would have to defer to my revivicor colleagues on that one. Not quite sure.
Sure. We have one more question from Mr. Arnold Davis, who is asking, what are your thoughts on the creatinine and the descendants' creatinine levels after the big transplant?
Yeah, I think, I had hoped that we would make an anephric donor. I would show you a beautiful pink kidney that makes urine and also clears creatinine. But the truth is I sewed it in on 3 pressors in DIC. And so I just don't know that I'm ever going to be able to show function in that model unless I was able to get a decedent that was literally within the first 24 hours of brain death. I just think that milieu is extremely challenging. And it's important to note that a 57-year-old brain dead donor with a high BMI and those kidneys would very likely end up having delayed graft function, just the native kidneys that came out, right? So it's not surprising then that we see delayed graft function in the pig kidneys. So I think, again, it's a limitation of this model. And I think we have to lean on the non-human primate work that shows these kidneys absolutely work well. They absolutely clear creatinine. They absolutely sustain the animal. And we have to pair that with what I think this preclinical human model has done, which is one, helped us validate a flow cross match so that we a priori can predict. And I can tell you about 2/3 of patients on the waiting list appear to have a negative cross match with these pigs. So that's great. So that's really helpful. And that's something I think we absolutely had to have before we could move into living persons. And then we also were able to test at human systolic pressures that we often see in dialysis patients who have hypertension and other things. It withstood that. We did not show early transmission of a PERV or chimerism in the periphery, at least not early. So those are all, I think, really important safety measures that add to the body of work in non-human primates that I'm quite hopeful is going to be enough to be able to sort of push this over the edge. And then I saw a great question. Did you stain for C5b through 9 or the membrane attack complex? We are in the process of doing it. As it turns out, there's really only a couple of places that do this. But it was something that I wanted to do very early on because I agree. I think if we see the presence of MAC, that would be very informative.
Excellent. Because you brought up the issue of the negative cross-match, a question that I wanted to ask is, how about patients who have high PRA antibodies? Do you basically think that, so does this go with a negative cross-match or it's basically irrelevant? And how about the swine leukocyte antigens?
Yeah.
So do you basically foresee that in the future there will be breeding lines adjusted to, the genetic makeup of potential recipients?
Yeah, that's a great question. I think that's probably way, way off in the future, just from a monetary standpoint. I don't think that's sustainable, at least not now, until sort of one of these gene edited pigs kind of makes it to market and really sort of they see an ROI on that. The question about, let's see, what did you ask? The question about the flow cross match. I'm sorry. Oh, the sensitization. So it's interesting. So we actually, the hardest part about the flow cross match was trying to find positive controls. And so we were looking for really, we tried all sorts of things. It's really interesting, but we actually see negative cross matches with highly sensitized patients with these pigs. And we don't think that there's a lot of cross reactivity. So we don't believe that we're going to see sensitization. In other words, if you were to get a porcine xenograft, we don't believe that that's ultimately going to exclude you from being able to get an allograft, that it's going to somehow sensitize you to the point you can't get an allograft. But again, we need to do this in living people because it takes more than 3 days for sensitization to occur. So those are things that we're looking at. But at least on the samples that we've tested, it's really interesting. Your HLA sensitization is not predictive of whether or not you'll have a positive or negative flow cross match with the pig kidney. And so this potentially opens the door for some of our really highly sensitized patients.
That's excellent. So the last question here in the Q&A from our audience, such a fascinating and important subject. In your paper, it seemed like that the descendant was normothermic, and out of curiosity, was this intentional to do so, or as to stimulate living physiology, or was mild hypothermia not induced because organs were not going to be procured from the descendant?
Normal. So the decedent, the decedent you can think of just like a normal sort of like a living recipient. So they were not hypothermic at all. They were kept at normal body temperature, just like a living recipient would be kept. The kidneys were hypothermic, kept on ice. When they came out of ice, they experienced the exact same warm ischemia time that typical kidneys experience in allotransplantation. Is that what you're asking? We did not put the kidneys on any sort of normothermic pump or hypothermic pump. They were simply stored on ice.
Yeah, I think that this answers this question. And there is one more, question that just was posted, that this is great work, and what are the moral and ethical issues going to be a problem in the future? And, I wanted actually to extend to this question. So 5 years from now, in an accelerated way where things, work perfectly, how do you envision that this approach is going to complement human allografts? So what kind of model would be ethically and morally, right to match patients needing transplant, with xenotransplants or allografts?
I mean, I think it's a great question, and something that we certainly will need to sort of have discussions around and have it keep pace with the pace of the phases of clinical trials, so that when the product is approved, we have sort of a way of doing this. I think that xeno will not, at least at this point, will not replace allo. As I mentioned, we think about 2/3 of patients will have a negative cross match. That leaves 1/3 for allo to have to cover. And if you look at about 90,000 people waitlisted, that's a pretty good deal, right? So hopefully it complements and we can get pretty close to wiping out the waiting list, and then move even potentially past that and be able to expand the criteria by which we offer people transplantation. As we know, many end-stage patients never make it to our waiting lists. But in terms of allocation, I think in many ways, xeno is going to have to really sort of tangle with the same things that I think allo doesn't do the greatest job at, which is making sure that transplant doesn't just become for the well-to-do. If you think about it, in many ways, transplant has very much become that, right? So if you struggle socioeconomically and you can't get your testing done, you may have been referred, but then you never get listed, or you get listed, but you never get activated, all these kinds of things. And so I think we are going to have to look at how we make this available. I certainly would hope that insurers would pick this up. Certainly, if it proves, to be as effective as it is in a non-human primate model, it's better. It'd be better than dialysis. So there's that piece of it. But how you sort of go about allocating, I think, is going to be challenging, and it certainly would be outside the purview of UNOS because they're not really over sort of this type of source. So I think it'll be hopefully something that as a transplant community, we can really drive together and have the appropriate people at the table to make sure we do it in as equitable a way as we can.
Well, thank you so much for a fascinating talk, answering all these questions. Congratulations for your efforts and accepting actually the challenges of, xenotransplantation and leading this field. I will close here and, thank to our attendees and, have a great day, everyone. Thank you so much.
Thank you so much. Y'all take care.